When I first started working in addiction a few years ago now, I was out in our detox unit and I was speaking to a patient who was in there for treatment of his methamphetamine use disorder. And he had quite a serious problem with methamphetamine. It's not the easiest condition to treat, as we all know. And I was sitting with him and I was trying to come up with a discharge plan, an ongoing treatment plan. And he said to me, "It's okay, don't need that. I've had the dream." I said, "The dream?" I go, "What dream would that be?" He goes, "You know, the dream." I said, "No, tell me, what's the dream?" He goes, "Well, you know, the dream, where what you do, you know, there's two paths that you can go down, and down one path is like everything bad is happening in your life, and everything is falling apart, your relationship, your marriage, you've got no job, it's all really terrible, and that's the drug use pathway. And then there's this other path, and this other path is all the good things in your life laid out before you, all the great things that are going to happen to you, and that's the non-drug use pathway. And you're standing there and you've got a voice and you've got a choice." And I went down the good pathway. He said, "So I'm all good." I said, "Okay, that's great." I said, "Now let's come up with a treatment plan anyway." He wanted none of it. And I saw him 18 months later. He was wanting his commercial licence back, and I hadn't seen him in the intervening time. And I said, "Well, how's it going? You know, how's the methamphetamine use? Any return to use?" He goes, "No, I had the dream." I said, "Yeah, okay." So I know how enchanting a quick fix solution is. I understand, I get it, and we're all looking for that. I also understand that politicians and lawyers don't have systems in place that always support them to think about the long-term hard road and the long-term gains, and to be in the game for the long term. Everyone wants a quick fix. So it's in that light that I'm going to talk about two very powerful pieces of legislation that lawyers and politicians have come up with in their way to try and solve this kind of difficult problem that we're all faced with. So this is the most personally and professionally difficult area of medicine that I have ever worked in, the area of mandatory treatment. So I'm going to talk to you about my reflections, and I'm going to talk about how these two pieces of legislation, so the Alcohol Mandatory Treatment Act and then the Volatile Substances of Abuse Act, how those two bits of legislation, where they sprung from. I'm going to talk about some of my work looking at the long-term follow-up of those individuals who've been involved in those programs. I'm going to give you some idea about how these pieces of legislation have shaped my thinking about work in this area, continue to drive and shape services, be that good or bad, and then how we're trying to use some of this knowledge going forward within in the area that I work in now for top-end health. So, Alcohol Mandatory Treatment Act. So this ran for 4 years, from 2013 to 2017. This act was sprung as an election campaign when the Country Liberal Party came to the election with a promise of removing the banned drinker register, which was in place at the time, and replacing it with this piece of policy that they could mandate and enforce problem drinkers into treatment. They won the election, and this policy, some would say that there was very little public consultation. The public consultation went for a month or so, and that the policy very quickly came into play. Now, the way it looked is that the referral pathway in was through the police. So that meant if you got picked up taken into protective custody, in the context of substance use, more than 3 times over a 2-month period, then you must be brought to an assessment unit for an assessment. So the referral pathway in was via police. The assessment units that sprung up, there was one in Tennant Creek, there was one in Nhulunbuy, there was one in Darwin, there was one in Alice Springs. And within these assessment units, so the police would kind of just drop people off all hours of the day or night. The assessment units, then they usually stay within the assessment units for about a week, Once they'd done their acute withdrawal within that assessment unit, they would be assessed by a senior assessment clinician who was someone usually had some background clinical knowledge about. The assessment clinician would see them, make an assessment, and they would take that person to tribunal. The tribunal consisted of 2 lawyers, a community member, and usually someone with some clinician with some drug and alcohol experience. The tribunal would then make a determination, and they could make various orders. They could release someone, they could make a community treatment order, or they could make a mandatory residential treatment order, so an MRTO. Now, the criteria for getting an order. You had to be an adult, so it wasn't for children. You had to be misusing alcohol. This is a very general term. As a result of the alcohol use, they had to have lost capacity to make appropriate decisions about their alcohol use or personal welfare. So there's a capacity clause in there. You had to be at risk of harm to self or others. No less restrictive interventions were reasonably available for dealing with the risk, and that they would benefit from the treatment. And in case for those optimistic, hopeful people in the audience, none of those terms were defined within the Act. So extremely vague, very general terms. Things like you didn't have to have an alcohol use disorder, the loss of capacity. When clinicians attempted to make any sort of capacity argument about people's right or ability to make decisions, we were told in no uncertain terms that capacity was a legal determination and legal decision. It was not based on any medical criteria, and that was up to them to decide. People could be subject to a 3-month order, which is usually the time frame, so it's quite a long time frame. For those of you who are familiar, there's various forms of mandatory treatment legislation all around both the world and in Australia. But I just want you to notice a few things about this piece of legislation. The referral in was through police. You had to just have these general terms of misusing alcohol. There was a capacity clause within there, but it wasn't defined. There's risk of harm to self or to others, and that the benefit from treatment was also within this piece of legislation, and that there's a 3-month order, so it's quite a long time frame. So I was quite a junior doctor working in this area. It was, as I said, it was quite ethically challenging for lots of obvious reasons that people here would understand. So a small piece of work that I did was to take a cohort of individuals who came into that treatment facility and who were given treatment orders over a 3-month time frame. I think it was in around 2015 I looked at this particular cohort. So there were 64 individuals who I looked at. And what I did was I looked at them for 9 months after they were given an order. And so I was looking at them a couple of years later, but I was just reflecting on what happened in the 9 months after this individual cohort they were given an order. So the first thing to say, it's really obvious, 96% of them were Indigenous. Very rare for a non-Indigenous person to ever be brought in to one of those treatment facilities. The average age was 39 years and most of them were men. So these are Indigenous homeless men who were brought into those facilities largely. So what I looked at was, well, did the making of these orders have any long-term effects? Certainly in the 9 months. What possibly could we look at? I tried to look at whether people were likely not drinking, whether they were likely to be drinking less, or whether they were likely to still be drinking heavily after these treatment orders were made. Now, there were two there, who were actually likely not to be drinking in that 9-month time frame afterwards. One of those individuals had bipolar affective disorder, that had that treated and had returned to country. So there was probably one person there who really seemed to not be drinking. There was one person who was likely to be drinking less in the 9 months after those orders. Overwhelmingly, 56 of those individuals were still likely to be drinking heavily. Now, the way I worked that out really was just, I didn't go and individually talk to these individuals, but I just looked on the computer record. So I can look at the hospital systems, I can look at all the local clinic systems, and I can look at episodes of protective custody, because if the nurses see them when they come into protective custody, and I can also see what happens in the prison if they get seen by the nurse in the prison. So I can start to pick up the data in that way. And what I looked at was, were they still being taken into protective custody intoxicated? Were they still ending up in ED with alcohol-related injuries, or ending up in ED intoxicated? Had they been taken back to jail? What was going on? And the clinics, some of those clinic systems I had access to. 2 people were unfortunately deceased, 3 were lost to follow-up. So then I tried to look at it a little bit differently. Obviously that's fairly grim sort of outcomes really, not overly surprising. I don't think anyone in the room would be overly surprised about this. But I tried to look at episodes of protective custody and ED presentations, so hospitalisations, and hospitalisations for all sorts of things, infections, boils, sores, trauma. So because maybe I thought if you put someone 3 months into a mandatory residential treatment facility and give them, it was quality care that they were being given within those facilities, maybe there'd be less hospital presentations, maybe they would be less likely to be taken into episodes of protective custody. So I looked at 100 days at risk before or after the order. So 100 days at risk, because what I had to do is I had to take out the 3 months that they were effectively in treatment. So I discounted those days, they didn't count. And I also, if they ended up in jail, I took out the jail time as well, because obviously you can't you're unlikely to go to ED while you're in jail. So what I found were really there were no change in the episodes of protective custody. The hospitalisations before or after an order did not change. And 45% were readmitted into the facility over 9 months. So there were several thousand episodes of care just in the Darwin assessment facility. And they represent about 630 individuals. So those individuals came in many, many times, so the police just kept bringing them back. So what we did see, the positive outcome here, is if you were mandated to have a residential treatment order, so that's going into was called the Saltbush Rehabilitation Centre. So if you were mandated to go in there, so not given a community order, then you're actually more likely to stay than if you were in there as a voluntary client. But many of the clients still didn't stay. That's no great surprise, but they either leave or abscond or get discharged or go to funerals or all sorts of things. But if you were mandated in, you had a 44% chance of completing a treatment program within there. Now that was compared to about between 24 and 44% if you were a voluntary client within that long-term treatment facility. So possibly it does increase your chances of staying if you're mandated into that facility. So now I'm just going to talk about another piece of mandatory treatment legislation. So sorry, the Mandatory Alcohol Treatment Act, new election, new policy, and it was ceased in 2017. So that piece of legislation, the brand drinker register, was brought back in, which is now what we're dealing with. So the Volatile Substances of Abuse Act. This piece of legislation is still going. It's been running now for 15 years, and it's something that I continue to work with on a daily basis. If you came to Darwin in the late 1990s, this is Royal Darwin Hospital in the 1990s. Now, on a floor in Royal Darwin Hospital, I don't know if anyone was working in the hospital back then, but there would always be between 4 and 10 young Indigenous men, almost always nasogastric tubes down, shackled to the bed, being treated for encephalopathy related to volatile substance use. So this is largely leaded petrol, episodes of encephalopathy, young Indigenous men. It was an absolute nightmare to work in that scenario and in that setting. So this was fairly typical. This is what was happening in the late 1990s in Darwin. So there's a big problem here. Now, if you actually try to look at what's happened with volatile substance use over the previous 20 years, it is really, really hard to get any accurate data about this, about rates of use, about rates of harm, about long-term outcomes. So this slide is very vague. I really can't nail it down any more clearly for everyone, except to say that overall, so that big sort of reddish arrow, overall, the rates of volatile substance use have declined dramatically in the last 15 years. Now, so what has happened is, though, around over a 5-year time frame, around about 2002, 3, 4, 5 and 6, there were a number of things that happened in the territory that probably had have a big effect on these sort of volatile substance use. So the first thing is, of course, lead was taken out of petrol. So the harms now are quite different than what was happening back at the end of the 1990s. So removal of lead from petrol. Then we had the rollout of low aromatic fuel, so technically unsniffable. It's hard to sniff it, you can, but the rollout of low aromatic fuel within communities. And then we had the Volatile Substance Abuse Act, which came out in 2006. So all of these things together have really changed the environment within which we work. So both the harms have decreased and also the rate of sniffing. But the end bit there is this squiggly line that said there are still outbreaks within individual communities, and it changes from month to month and from community to community. And every now and then, too, avgas will raise its sort of ugly head, and suddenly you will get children who suddenly are starting to be exposed to high lead levels again. So it's quite a volatile situation. So when trying to nail down, what about deaths? So, deaths from volatile substance use, very, very hard to get data on this as well. So we know that prior to 1987, between 1980 and 87, really short time frame there, 121 deaths in the NT were recorded as being related to volatile substance use. Huge numbers. This is a terrible statistic. But we know the deaths were very poorly recorded back then, so that data is probably very inaccurate. Then there's 1998 to 2003, 37 deaths Australia-wide attributed to volatile substance use. Now from 2007 to 2022, so to this year, in the NT, it's about 17 deaths that are attributable to volatile substance use. So many of those will be related to hypoxia, so technically these will be overdose type deaths. Many of them are related to suicide. So they're the two strongest sort of correlations we've got in terms of cause of death. The others are kind of misadventure, falling off cliffs, getting lost, burns, those sorts of things. So this is the kind of framework we're working in. So just to sort of highlight to people, and not everyone here is probably a clinician, but when we're talking about volatile substance use, I'm not talking about sniffing nitrous oxide and the inhalant use that we often see elsewhere in Australia. Up here in the territory, we're largely talking about sniffing aromatic hydrocarbons, which are breakdown or end products of the petrochemical industry. So what we're talking about is toluene, benzene, xylene, propane, butane. And these are products that we see in a broad range of industrial uses. And so these are in petrol, paint, and aerosols. So that's what the kids up here are largely sniffing. And often this can be quite confusing when you're trying to work out what people are actually using and how to think of this clearly, clinically. And you come across, these are pictures from various communities of what people are kind of sniffing. And silver paint is quite popular because there is a bit more toluene, I think, in silver paint. So apparently toluene is something that you can add to paint, and it helps the microparticles and the colour, the bits of paint. Instead of, if you'd actually dissolve the particles in water and tried to paint with water, you wouldn't get a nice even spread. So if you dissolve it and you use toluene as one of your bases, your solvent, then you can get the paint particles all distributed very nicely within the paint, and it dries really nice and you get a good coat. So anyway, a lot of people up here will sniff paint, but they also sniff deodorants, so they're going for the propane and the butane. So, but there's also still a lot of petrol sniffing. So these aromatic hydrocarbons, the big thing about them is that they're very lipid soluble. So they cross the cell wall very, very quickly. And if you're talking about encephalopathy and cerebral effects, so they cross cell walls and they have a broad sort of kind of effect throughout the brain, and they cause a type of delirium, but very, very broad effects in the CNS. So this is how I tend to think about volatile substance use and the causes. Now we know there's lots of risk factors for volatile substance use. Those risk factors, I tend to summarise them. I largely see this as a problem with emotional dysregulation. So we know, particularly when we're talking about young people, we know they sniff volatile substances. Firstly, they're readily available. It's not a criminal activity. But essentially they do it because they're hungry, because they're bored, and because they're distressed. So they're trying to manage some sort of emotional dysregulation issue. Now you will notice this is not greatly different from adult substance misuse. The slight difference might be that a lot of the emotional dysregulation that drive adults to continue to use their substances is around the intoxication and withdrawal states that they're trying to deal with as well. There's less of that with our young people who use volatile substances. Their emotional dysregulation is more strongly driven by lack of safety, lack of security, and the trauma and the very distressed backgrounds that a lot of these kids, as we know, they suffer. They're the most disadvantaged cohort that I've ever dealt with. They've got tremendous trauma and very disadvantaged backgrounds. Now, hungry is an interesting issue. We know that particularly toluene is an appetite suppressant, but it also will, so kids will sometimes sniff because they've got a lack of food security. But ultimately, it also does cause growth impairment as well. And boredom, well, we know that's a common, children everywhere, young people everywhere, and that emotional distress that I've talked about. So, and we know what they get from petrol sniffing. If you ask kids or volatile substance misuse, they feel better, they do get a high, it helps them to forget the feeling of freedom and also the feeling of power and rebelliousness. None of this should be a surprise to everyone here. So, just to quickly recap, because I feel like when I'm working in this space, all I do is perpetually disappoint everyone by saying there is no magic fix here, and really just trying to articulate really clearly what is the treatment for this anyway. So if the causes and the drivers, hungry, bored, distressed, then the side effects or the things that we're really ultimately trying to avoid: suicide, overdose, misadventure, psychosis, drug-induced psychosis. This is a big problem with volatile substance use, and I'll talk a little bit more about that later. Impairments in growth and possibly injury from lead. So, what's the treatment for this? We have national guidelines, they're consensus-based clinical guidelines. We don't have a lot of literature, a strong literature base that says what evidence-based treatments there are, but we do know basically you take people to the medical clinic for a medical review, brief intervention. So this is the sniffer story. There's some, kids do need information about the potential harm of their substance. Diversional activities, so you've got to keep them busy. Keep them engaged with other things, treating that boredom. Psychological treatments, nothing magical about this. If you can treat their underlying trauma, loss, grief, those sorts of things, there might be specific psychological interventions that help. Territory families need to be involved. Usually this represents profound neglect of many, many sorts. Now there are AOD-specific residential treatment interventions that might be appropriate, particularly where there's a lot of chaos, a lot of dysfunction, and you need to remove kids in the short term. But AOD-specific interventions are kind of should be reserved for some particularly high-risk individuals. So, well, if we have a little look at the Volatile Substance Abuse Act. So once again, the referral comes in largely through police, but it is slightly broader. Family members can actually make a referral for assessment under the Volatile Substances Abuse Act. So pretty much anyone can refer to an assessor for an assessment under the Act. The referral has to come through an official form. It comes through what's called a Form 33. So often what the VSA team in Darwin get, or I don't know about, is a Form 33 filled in by a policeman who's spotted 20 children, or not 20, say 10 kids sniffing on a beach in Gallowinka or somewhere, and we'll get a list of 10 names sent in through to the team in Darwin. One of the problems here is that is interpreted as a referral for treatment. And obviously that's a misunderstanding about what actually a Form 33 actually is. It's a referral for an assessment under the Act. Nonetheless, referral pathways largely from police. You've got to be at risk of severe harm. So there's some effort here to say not just any old harm, you have to be severe harm. A treatment will be in the best interests of the person. Once again, fairly vague. The person cannot be adequately protected from severe harm by any other means, and they've not participated in a treatment program since the assessment is done. So there's no capacity clause in there here, so you don't have to have lost capacity. You don't have to be an adult. So you could refer an adult under this Act, and people often do, but largely children are the ones being referred. The orders can be up to 4 months, so once again a very long time frame. The Act does have some other parts, for example, that allows the development of community management plans as well, which are quite a good part of the Act if you can get them happening. So this just, in terms of, if we look at all treatment orders prior to 2019, so I had a little look at these. So I chose 2019. I'm not looking at orders that have been made since 2019, and that's because around about prior to 2019, the only two treatment options that were available for someone who was referred under the Act were to go into residential rehab, or as a voluntary client, or to be made to go into residential rehab. So there were very little other treatment options that were explored or tried by the VSU team, certainly in Darwin. So around 2019 we tried to change that, and we've tried to create a different model of care. And I also know that some of the treatment providers, such as CAPS, have really tried to do much more aftercare and much more reach out and much more sort of long-term care. But prior to 2019, pretty much if you were referred to an assessment under the Act and you met that criteria, then your treatment option was you get a mandatory treatment order or a voluntary treatment order. Now, there were 372 voluntary treatment orders made between 2006 and 2019, and there were 132 mandated treatment orders. So those 132 mandated orders represent 84 separate individuals. So you can see that many of them get a couple of orders in their time. So I once again tried to look at what was the long-term outcome of these individuals. Now, so you can see, so there's a cohort of 84 individuals who were followed up. Now, so these were all who had a mandatory treatment order made before 2019. So I looked at them this last month in this year. So you can see for some of those, this actually represents a 15-year follow-up. And for some, it will just represent a 3-year follow-up. So I just looked at everyone a month ago to say, well, where were all of these people who've had mandatory residential treatment orders for VSU? 100% are Indigenous. So we can just reflect on that number in terms of racism and stigma and bias and all of those issues that Dan has raised earlier. So 83% are male. So by and large, these are young Indigenous men. The median age was 16, but we've got a whole range there from 10-year-olds to 37-year-olds. It does, just as to note, about a quarter of the referrals that we get for VSU are under 12 years of age. So 4 of those individuals were deceased. The outcome for this cohort of individuals is really quite distressing. So when I spoke to Dan earlier, I just said, look, yes, there are really good outcomes for treatments with substance use disorder, far more positive than the stories that we tell. But this is not a homogenous cohort. These are really, really complex, the most difficult cohort that I've ever had anything to do with, and they don't all have good outcomes. So 27% would have an easily identified document episode of assault. So they've presented to ED being assaulted, they've presented to the clinic being assaulted. 9% have rheumatic heart disease. So that is probably around 10% if you looked a bit harder and a bit longer. Highest rates anywhere in the world of any cohort. They're also the least likely to follow up with their monthly LA bicillin. So the highest documented rates of rheumatic heart disease anywhere in the world is 10%, and that's a community group in Meningrida. So these are approaching that particular cohort. 21% will have a documented psychotic condition, massively high. So volatile substance misuse is a really strong risk factor for developing triggering a drug-induced psychosis, or indeed as both a trigger and a driver of chronic psychotic conditions. This is not well described in the literature, and but it's a very clear problem that I see. 7% had a cognitive impairment, and I know that Dan has done some work on looking at long-term cognitive impairments in individuals who use volatile substance misuse. The issues that I see in my personal clinical experiences, there are issues with impulsivity, with decision making, with autonomy, with frontal lobe function. If you're currently using, with the access to the volatile substances that kids are currently using, toluene, benzene, xylene exposure. It's different. If you had an episode of lead encephalopathy, then you are likely to have long-term cognitive impairment. So even back in the days of leaded petrol, if you didn't have an episode of lead-induced encephalopathy, your cognition eventually improved. So the outcomes are actually quite good, unless you had an episode of lead encephalopathy. Those outcomes are not so great. And that cohort do have a long-term cognitive impairment. The cognitive impairment that we tend to see with current volatile substance use is those issues with impulsivity, frontal lobe function. The whole question about how recoverable that is, I think people in here have a lot of clinical experience with this, which would say it can take a while to recover. Generally, it probably does largely recover. That's my impression. It will not recover, though, if you trigger psychosis. So if we look at so those over 15 years, who's got a documented cognitive impairment from that particular cohort? So 7% did, but only one of those individuals did not have a chronic psychotic condition. So that individual had some, I actually never got to the bottom of what it was. They were under disability services. It had happened 10 years previously. They had had some major event related to their volatile substance. It might have been an episode of hypoxia or an assault. I don't know what it is. Had a very significant acquired brain injury and a documented cognitive impairment. All the others, yes, they had cognitive impairment, but they also had a chronic psychotic condition as well. So they're very closely related. So 82% had returned to VSU within the year after they'd had their treatment order. 85% were referred again. So they simply got referred again. 64% went on to have absolutely clear evidence of another substance use. So this is what we know. As soon as they can access something better, they do. So adults rarely go on to use volatile substances, particularly females. It's extremely unusual, extremely uncommon. But young men, we do see some adult men continue to use. My experience with this is they will only access it if they cannot access the alcohol, the cannabis, other better substances that simply feel better and just feel better. Whereas when you're a child, this is all you can access. So as soon as they can move on to cannabis or alcohol, that's what will happen. And 57% of them had a significant period of incarceration after their order. So that's no great surprise, but these people are ending up within the prison system. And when I say significant periods of incarceration, are actually charged and in prison, not just taken into protective custody, so that's where they end up. So, looking at completion rates, if you were given a voluntary order, so you referred into the assessment team, they said, yes, you meet criteria, but would you like to go voluntarily into residential rehab? They said, yes, they will go voluntarily. 28% of them completed those treatment orders, whereas if you're mandated in, 44% would complete a mandatory treatment order, which is coincidentally quite the same as with the adults. So most people still don't complete the treatment order, even though it was a court-ordered process. So I'm not sure if I might have forgot to tell you, but what happens is you see the assessor, they say, yes, you meet criteria, and yes, we recommend a treatment order. It goes to the Chief Health Officer, he signs it off, then it goes to court. So the decision is made by a lawyer in court. In theory, the person is meant to have their own legal representative, but I don't think I've ever seen anyone adequately defend themselves against an order that's going to be made by a court and by a magistrate. So you've got a court order, and the police then go and serve these individuals with their court order to be told, you have to go into residential rehab, and off you go. So but even then, even with that, many of them will not complete their treatment. And there's a lot of funeral business. There are families who want their kids, their children returned home. There are kids who run away. No one has a detention facility to detain these kids. But anyway, you were slightly more likely to complete the treatment. So what does that do? If you do complete the treatment, what does that do? Unfortunately, so having a little look at within these two groups, if you were voluntary or if you were mandated, or if you completed or didn't complete, did it make any difference? Unfortunately, there's no difference. No difference in the chance of ever being referred again. No difference to the chance of being referred within the year. No difference in rates of development of other problematic substance use. So unfortunately, completing the treatment didn't seem to make any obvious difference there. So, look, I just want to reflect a bit now. So this is a type of civil commitment piece, these bits of legislation. So then it's a bit different. There are other pieces of mandatory treatment legislation, for example, court diversion orders, which have a little bit more evidence. They're perhaps a bit more acceptable. They're a bit more internationally acceptable as well, whereby you get a degree of choice. You either go to jail or you go into treatment. And that's a court diversion process, and that's a bit different. This is a civil commitment process whereby these people have not committed any crime at all. So I just want to reflect on how these pieces of legislation look, because down the one end, you've got bits of legislation that are solving a social and political problem. And down the other end, you've probably got something that might be more trying to affect an actual medical treatment kind of helpful model. So down one end, you've got police referral pathways in, treatment decisions purely made by courts and by lawyers. You've got very long periods of effective incarceration. There's no capacity clause within that legislation, and the risks of harm are very ill-defined, and it's very easy to make those sort of orders. Down the other end, you might have something where there's a medical referral pathway in. Decisions for treatment orders might be made by a tribunal. Orders will be short. There will be a restoration of capacity, which would then trigger release, and it really has to be severe risk. So you can move bits of legislation along these kind of spectrum to see really what are we doing here. And I would suggest that the Mandatory Alcohol Treatment Act is much more down the down the end of the police referral pathway and trying to solve a social problem and a political problem. The volatile substance use might have some components a bit more down the other end of it. So how do I think about some of this now, and how has it helped shape some of my thinking? So what the Mandatory Alcohol Treatment Act, and working with the individuals within that Act, I now know these people quite well. And what I can say, and my experience and knowledge with this cohort, is they're not going anywhere. These are long-term, heavy drinking individuals. They're all homeless. And mostly they're Indigenous men. They've been living in Darwin for a very, very long time, and they're not going away. So there is no magic return to country. And that same cohort is still there to this day. And I know there's about between 400 and 700 of those individuals within the Darwin community. So when I look at this, now I know that there are experts on homelessness probably in the audience, so I'm not going to give you exact numbers about this, because once again, homeless data is also a little ephemeral depending on how you define homelessness. But within Darwin, we've got a massive problem with homelessness, far greater than anywhere else in the country. And that's a huge number of people have insecure overcrowding, insecure housing, no tenancy agreements, that sort of thing. Then within that, we've got a cohort of individuals that we would perhaps classically call homeless, that they're sleeping rough, all these camps around Darwin. But not everyone within those camps, not everyone is there. They're not drinking. They're there because of issues with a lack of accommodation. For women, it's escaping domestic violence. They might be just moving through. Various reasons why people are living in all these multiple camps around Darwin. But within that, there's a core group of long-term homeless individuals with very serious substance use issues. You don't get to be in that place without overwhelming psychosocial drivers of your condition. And within that cohort, there's about 400 to 700 individuals. They're all the ones that were dragged in for mandatory treatment days. So when I'm trying to talk to say doctors in the hospital about how to think about this, what I would say is to try and help people and do whatever you can to stop this drift in. So you come in, perhaps you've done some time in jail or you're visiting someone, then before you know it, your accommodation is very insecure and you start to be sleeping rough, and then before you know it, you every time you end up in hospital with an injury or an assault or a broken hand that doesn't get fixed, you're accumulating grief and trauma, you're more likely to drift further and further into that middle cohort. So if you can spot people on the outskirts, on the fringes of it, maybe there is a return to country. Maybe you can help them fix the hand. Maybe there is something you can do to turn that process around. So stopping the drift in is not a bad concept, but once they're there, once they're in that core group, then there isn't really an easy magical fix there. Sending them back to community is not going to work. Also, this cohort doesn't access primary health care. They access their health care through the emergency departments in the hospital. They don't go to Danila-Dilba, they don't follow up in that way. So, to try to sort of end on a slightly more optimistic and positive note, and lest I be accused of therapeutic pessimism, we have developed a program. We call it the Take a Break program. And really what was happening is we run a detox unit, and actually Ingrid and we've got some members of our team there. Ingrid's our manager in the detox unit. So it used to be the old Berrima low security jail. It exists because of the mandatory alcohol treatment program. When that treatment program was removed, the old treatment facility there was translated into a voluntary treatment facility. So we do have that treatment facility. So for that I'm very grateful. But it used to be a jail, looks like a jail, feels like a jail. It's in behind Don Dale. It's still got barbed wire and razor wire and fences. So, and what we were finding was that the same cohort kept coming into the detox facility, and they'd come through the sobering up shelter. So the sobering up shelter is co-located out the back, and to the incredible people who work in the sobering up shelter, they see 40 people every night. They're brought in, often intoxicated. They clean them up overnight, or also called the spin dry, and give them a shower, give them some breakfast, and they wake up, and if they say, yes, I'm ready to have a break from my drinking, I want to do something about my drinking, then they can be streamlined straight into the detox unit. So, but we were getting a cohort, and what was happening was they would say, yes, I want to stop drinking. They'd come across, they would stay for 5, 6, 7 days. We would do all these referrals onto residential rehabs. We're very lucky in the Territory. We do have good access to residential rehab facilities, and then payday would come and they'd be off again. And then they would come back 2 weeks later and they'd come in and we'd give them their thiamine and re-prescribe all their antidepressants and antipsychotics and everything else, and then they would just go again, and we were on this terrible cycle. It caused a lot of burnout for staff, actually. We'd wonder what we were doing, and all these huge numbers of referrals were going off. So we introduced a program called Take a Break. Now, Dan, I'm really impressed. You've got a whole reality television show and lovely communications and whatever about your process and facility. So I've got a nice brochure here from Top Intel, and Carly will print these in colour if I'm lucky. So this is about the Take a Break program, so you can have a little look at what it's about. So the idea is if you come into our facility more than 3 times in a 12-month period without progressing to treatment. So and treatment can be anything. Treatment could be residential rehab, it could be taking naltrexone, it could be following up with your GP, it could be going to AA, smart recovery, any sort of treatment at all. So, but if you come in 3 times without progressing on to treatment, then what we do on the 4th go, we offer the Take a Break program. We say, perhaps this might suit you. And then what we do, if people are interested, they get offered a respite bed. So it's largely a respite model of care. So what we would say is, you're welcome back in our facility. So you are not banned. You're welcome back in our facility. And why don't you come for 1 to 2 weeks? And you can come, it actually works out about every 2.5 months, but 3 months is from the day that they're admitted. So you're welcome back in our facility for up to 2 weeks stay. We're pretty flexible around that too. And here's the date that you're due back. So any time after that date, we will just streamline you straight in, and no questions asked. You can come back into the detox facility. If you want to come back in before that date, then you are welcome, but it's on a case-by-case basis, and we need to have a discussion about what the benefits of the detox would do. So we don't streamline you in. Now, the exceptions to that would be they end up in hospital. We've got, at any one time, we've got 1 or 2 individuals now on a Take a Break program, but we've got a lady there. She ended up in hospital, fractured leg from an assault. She really wants to come back into the unit. She's not due for her respite bed yet. We, of course, are going to let her come back in. And what that does is we try to work on the patient's goals. Now, the concept is it's not take a break from us, it's a take a break from drinking, from whatever else is going on out there. Because, obviously these people's lives are very, very complex. They're very difficult. It's not easy to live in the long grass in Darwin. So take a break from what's going on out there, but they might not be ready to stop long-term drinking. And actually, we don't have the right language to describe what's going on for these individuals, I've got to say. But the whole idea of committing to residential rehab or making big changes, they're not ready for that yet, but they do want a break. So they come back in, we streamline them straight in, no questions asked. We give them thiamine, we try to get all their immunisations up to date, we sort out their medical issues. And we work on their personal long-term goals. That's the idea. So we've currently got 39 individuals on our Take a Break program. So a few of them don't use it at all, so they were put on when there was a whole, something going on in their lives or some sort of thing happening, and then they haven't used it for a year. But a lot of them use it quite regularly. Now, half of those individuals were the same cohort that came into that facility under mandatory alcohol treatment days. So just to reiterate, they're not going anywhere. also I'm quite proud of that, because the medical staff and the nursing staff that were working with them back in mandatory alcohol treatment days worked really, really hard at providing a really high quality of care. We knew this was ethically very challenging. These people hadn't committed any crime. They were forced to undergo withdrawals from alcohol against their wishes, and we really worked hard to try and make it a quality kind of service. So anyway, half of them have now, half of the Take a Break group were there back in those days, so I think that's great. Now, the top goals that they've nominated, surprise, surprise, they have drinking goals. So what they would say, they actually do identify that the alcohol is a problem. So contrary to popular thinking, they actually do have alcohol-related goals. So they want to try and control their drinking often, is how they would look at it. They do dream of one day not being drinkers in the long grass in Darwin. So that is really important to note. They all want accommodation. And I don't know about you, but I personally get very offended when people tell me that drinking in the long grass in Darwin is a lifestyle choice. Everyone wants home, everyone wants safe, secure accommodation. So, and that's certainly what this group will nominate as their second goal. And the third is they want connection with family. So we try to work on those goals for them. So this is the last thing that I'm really going to say, but it's not, I guess, different to what Dan is saying. So one of the problems with these pieces of legislation is they can really take the focus away, money away from where I personally think that the focus should be and where the funding should be. The whole VSA program for top-end health service for many, many years was driven by the Act, the VSA Act. So it is akin to your whole treatment and program for mental health is based purely on whether someone's sectionable or not. Imagine dividing your whole mental health service based on whether someone was sectionable or not. In effect, that's what has happened because of the Volatile Substances of Abuse Act. The whole focus was on working with the Act and developing and putting in applications for orders and treatment orders. But what about all the brief intervention, all the harm minimisation, all the kids who just sniff once or twice, the experimental users, anyone who doesn't get sent a Form 33 to the group in Darwin? What about all of that stuff? And really none of that was, certainly from a top-end health service point of view, really wasn't being focused on. It was all just about trying to work with the Act. We have tried to change the model so that's not the case. The Mandatory Alcohol Treatment Act, $24 million a year to run the Mandatory Alcohol Treatment Program. So be very wary about, these are very expensive programs to run, so I think they can be very distracting. I'm not saying that mandatory treatment has no place, but I just think this needs to be kept in perspective. So don't be overwhelmed. So working in the volatile substance misuse space is absolutely overwhelming very, very quickly because these are very disadvantaged, difficult to work with cohort. It's a really challenging kind of space. So sometimes I'm constantly saying, actually, my job is to be the person who isn't overwhelmed by this, who can continue to try and work a way forward and to keep working within this particular cohort and this in this space. And of course, thinking big picture. We're in it for the long game now, and I think, you and I, we all know this, but taking a long-term approach and a long-term picture is really important. People cycle in and out of treatments. There is no magical, apart from my one person who had the magical dream, there are very few short-term fixes here. So people cycle in and out of treatment and many, many times, and they learn each time and they change as they move through treatment. So even though my particular small audits there have very grim kind of feeling about them, they shouldn't be overly surprising. 3 months in a detox facility under forced treatment rules, of course that's unlikely to make any long-term changes for people. So how do we take that information and ensure that what are we really trying to do here? And perhaps it gives us a bit of a way of thinking about it in terms of, we know these people are going to be incarcerated at massive rates. How do we use that information to work with this? We know that these kids are going to go on to use something else. How do we use that knowledge to work with this particular cohort? We know there's profound psychosocial disadvantage and neglect here that is driving their ongoing use. How do we work in that particular space? That's all I've really got to say. Thank you for listening. Any questions or comments? Have we got time for questions or comments? That's it. Yeah. Yeah.
Thanks so much, Chris. It's really valuable to hear your experiences and expertise from over such a long period of practice. So in Sydney, St Vincent's Hospital has received a bucket load of funding to set up and build from the ground a managed alcohol program. And it's obviously something that's been talked about a little bit in circles here with, different focuses on what kind of populations should be doing, focused on or clinical versus kind of non-clinical approaches as well. I was wondering what your perspective is on whether that might be something that could be valuable for that kind of core group that you mentioned, that we're sort of trying to avoid people into. But once people in there, do you see that as something that could happen here?
Absolutely. I think it would be fantastic. I think, look, we all know you need multiple solutions and multiple options. I think it would be extremely difficult politically, and the social sort of climate up here, because people are still a very stigmatised group. They really want to punish them. You can go into Fanny Bay Jail here, and there's a on the wall in Fanny Bay Jail. There's a written sort of transcript of something from about like 1950, and it's a young Indigenous man who's been incarcerated for 3 months for public drinking. Like, we're just still doing the same thing. So the political and social sort of discussion is still very much around punishment kind of oriented there. So I think that would be the problem. But from my point of view, absolutely, and I think, because this is exactly the cohort we've got on Take a Break, that they really, there's a lot of other drivers of their alcohol misuse, and I definitely see a managed alcohol program would be really brilliant in that space, because what I see, or what my understanding of that research is that it really it decreases people's threshold for ending up in hospital. Doesn't stop it altogether, but they get less hospital presentations if you can have a managed alcohol program, and it allows a reconnection with family. So there's a place that they can go and that family can potentially visit and reconnect, and that hits the nail for the goals of these individuals. Safe, secure accommodation, reconnection with family, and a way to control their drinking. I think it's exactly what they're saying they need, but there's a lot of them. Like managed alcohol programs, I think they're pretty expensive, and we've got a lot, like for people, hundreds and hundreds of individuals. So that would be my only problem with that. It's a small cohort. Yeah.
That's Chris, great presentation. I think the thing that comes from me around what we talk about is how we become more sophisticated in talking about the breadth of issues that we face. So I think we, because of the nature of the underfunding in our sector, we don't talk about the complexity of what we see. Well, we don't have a good segmentation of the challenges of how we target different types of interventions in different ways. So I think your comment around, like, we see a nail, and it's we have one approach to it. I'm just reminded, like, if we go back to the 19th century, we had this symptom called breathlessness, that people were breathless and they came in and we didn't understand anything about pathology or other factors, and we had just a single approach of breathless, even though it might be cardiac lesions or respiratory or structural or range of issues. And I feel that's where we are with addiction. We have one symptom, which is people using drugs, and we have a very sort of blunt instrument in terms of what we do with that. And yet there's a whole range of physical health, mental health, social and cultural complexity that's overlaid on top of that. Yet we don't have any sort of staged approach for how we, first of all, identify people and identify what the level of sophistication of response we need. So I'm just thinking about cancer and, like how far we've come, particularly with childhood cancers. So, you used to have cancer. So if we just talk about cancer, if we just say all cancers are the same, but we know that cancers have very different mortality rates. And so if you have brain cancer versus lymphoma, you have very different outcomes in terms of childhood cancers. But we just talk about addiction or other substance use disorders as if they're all the same. And so the question is how do we get more sophisticated in talking about the separation or segregation of different presentations in this space and the need for different levels of complexity, different levels of sophistication in managing that complexity. Because, and to what degree we reinforce those sort of perceptions by just seeing it as a single phenomenon that we have a single response for.
Yeah. So I guess a couple of things spring to mind. So it's such a different cohort, those on the opiate pharmacotherapy program, in this sort of urban Darwin sort of setting, and a young Indigenous man in Maningrida. It's a really, really different cohort. It's not a homogenous group at all. And yes, that idea that yes, that the recovery, and as I was talking to you earlier, I know there are really good outcomes and really positive outcomes for substance use long term for the large cohort, but when you nut down, they're not a homogenous group, and for some groups it's a really much more of a struggle and much more damage kind of done along the way. And so, I think we've learnt from, or at least I've learnt, when you look at homelessness, it's the same sort of problem. Like, all homelessness is not the same, and you can't really tackle homelessness until you work out, well, there are the vets here, or there are the women fleeing domestic violence here, and there are the people with mental illness here, and there are people, with physical disability here, and they're different. They're all different. They all require a different response. But while it's just all homelessness, it's overwhelming and it's too much. But once you start to kind of break it down like that, you go, oh, actually, there are a cohort of services here for this group, and there's some for this group, and there's, that you can kind of work a bit more clearly, and so it's a more sophisticated kind of approach. I agree.